Dr. Ipsita here now.
Good morning, everyone. Myself, Dr. Ipsita BARMAN, is here to present on the topic Indocyanine Green Enhanced Transpipilar Thermotherapy versus Transpipilar Thermotherapy for treatment of thicker tumors of retinoblastoma, a randomized controlled trial. So to start, retinoblastoma is the most common primary intraocular malignancy of childhood. The focal treatment includes laser photocoagulation, transpipillary thermotherapy, cryo, and brachytherapy. TTT is a sub-photocoagulation heat treatment using the infrared radiation of a diode laser directed at each tumor. So ICG is a green dye that binds tightly to the plasma proteins and hence remains confined to the vascular system. It also works at the peak absorption spectrum of 800 nanometer. It has been seen it is non-toxic and safe in children. So retinoblastoma most commonly present with leukocoria, strabismus being the second most common clinical feature. It can also present with red painful eye and also diminution of vision, and atypical presentations include orbital cellulitis, hyphema, and thysis bulbi. So lacking in knowledge in our study is that very few studies are there in this treatment modality. Most of the studies done are retrospective in nature, no comparative study between TTT and ICG enhanced TTT, and no study has reported the usage of ICG as the primary or upfront treatment modality for the treatment of tumors. So rationale behind this study is that retinoblastoma is a non-pigmented tumor, while absorption of TTT is better with the pigmented lesions. ICG is a chromophore which works at the similar light absorption spectrum as the wavelength of the infrared diode laser used for TTT, and hence must augment the effect of TTT. So ICG enhanced TTT may reduce the number of focal treatments required for thicker tumors as compared to TTT alone and achieve a greater tumor height reduction. So the primary objective of the study is to evaluate if ICG enhanced TTT achieves a greater tumor reduction as compared to TTT, and secondary objective is to compare the complications rate between the two groups. So we included the tumor which height includes more than 2 millimeter, largest basal diameter less than equals to 10 millimeter, tumor not involving the fovea and with clear media. We excluded those tumors involving the fovea, any media haze, calcified tumors. So it is a randomized control trial for a period of 1.5 years done in RP Center for Ophthalmic Sciences, AIIMS, New Delhi. So the basic methodology includes the clinical workup and examination under anesthesia to note the largest basal diameter and the height of the tumor. So all intraocular RB eyes which require the chemoreduction prospectively evaluated in the inclusion in the study after 2 cycles of chemotherapy. Individual retinal tumors which fit the inclusion criteria were divided into 2 groups based on the simple randomization table. And focal treatment was continued next 4 consecutive EVAs or till the tumor height achieved a less than 2 millimeter. These are some clinical pictures. So the procedure includes a 3 millimeter spot diode laser of 810 nanometer infrared laser using 20D lens has been projected into the tumor, which heats up the tumor by 60 to 65 degree Fahrenheit, and then the energy and the duration of the TTT is increased till mild graying of the color noted. And in ICG enhanced TTT, the dye is delivered intravenously 30 seconds before the laser treatment. So the specific tests were applied using the data analysis. The baseline characteristics of each group were comparable. The results. Coming to the results, the change in the tumor height as well as the percentage change in tumor height, it showed a significant difference between the 2 groups with greater reduction in ICG enhanced TTT as compared to TTT group. So these are some clinical pictures. As we can see, in the 4th examination under anesthesia, there is a complete scarring with ICG enhanced TTT and fish flesh regression in TTT group. So comparing the side effects in between the 2 groups, there was no statistical difference. So to summarize, the primary outcome said, the combined use of ICG enhanced TTT in thicker retinoblastoma has shown significant tumor height reduction. There was no significant difference between the 2 groups in side effects. So to conclude, the combination of ICG enhanced TTT is a potentially better treatment modality in terms of treating the thicker tumors in retinoblastoma as compared to TTT alone. Limitations of the study is that it is a small sample size, also small duration of follow-up. So we recommend the combination of ICG with transpeptide chemotherapy that appears to be relatively better treatment modality as compared to conventional TTT and needs to be explored further in thicker intraocular retinoblastoma. Thank you for your patience hearing.
Thank you.
Thank you. Thank you.
I think your outcome points were very, you could have had a wider outcome measure in terms of recurrence rates, number of sites treated, number of sessions treated, the total duration. I think you were just looking at regression and side effects.
Definitely, sir. I'll take your advice. I'll do it, sir. Thank you, sir. Thank you.